either something's blocking it, a clot maybe, and the tissue's dying. So altogether, that gives you a heart attack, which is something you hear about, you see all the time on TV, someone collapsing, clutching their chest pain. Yeah, it's really simple when you break it down. So we're going to talk about that today. So I thought we'd start off with a quick quiz of anatomy. You've got to know the basic structure of the heart to learn about what goes wrong. So hopefully you'll have covered some of this in GCSEs or A levels. So if Mark, we could just do the first poll question. If you could just tell me what number 1 is.
Right, okay, let's see if this poll thing will work. One second.
Fingers crossed.
Launch. Okay, so you should have that first one up on your screen now. It looks like it's put all 3 labels in one poll question there.
Oh, that actually probably works better. So guys, just feel free. All the answers are anonymous, so have a go even if you don't know. Have we got some answers coming in?
Yeah, so we've got about 60, 70 so far out of 340 attendees. So I'll just give that another kind of, maybe another 20 seconds just for a bit more time. They've got to do all 3 as well, so we'll give them a bit of time.
Yeah, keep them coming, guys. Have a think.
So I think when we get to about 300 out of the 342, if it's still going up, I'll leave it for. Looks like it's starting to slow down now.
Okay, cool.
Right, okay, I'll end the poll now.
Perfect.
I'll share well, and then you should be able to see those, Minnie, to talk through them.
Oh, great. There we go. Let's see if we can get that slide to work. Perfect. So yeah, that's great. 82% getting that one right. That is the aorta. So this is the one that transports oxygenated blood that's coming in from the lungs down to the left atrium, left ventricle, and then out to the rest of the body. And there's a massive vessel, like you'll see it in your first year dissections. It's really, really big, really elastic, because it's under such massive pressure. Number 2 as well, great, 75% if you're getting it again. That is the left atrium, so that's where oxygenated blood comes in from the lungs, from those pulmonary veins, and then down to the left ventricle. Number 3. Oh, there's my slide going behind. There we go. So that's the pulmonary valve. So blood's coming down from your superior and inferior vena cava into the right atrium. It's down through that tricuspid valve there. That's that one. And then the pulmonary valve here into the pulmonary artery. And the blood's traveling to the lungs there. So really good job, guys. You definitely know your anatomy. Go on to the next slide. There we go. So as I said before, the heart's a muscle, so it needs its own blood supply. Obviously the aorta is going to the rest of the body, so it needs its own vessels to carry the blood, which will supply it with the oxygen and the glucose that it needs to respire to be able to pump that blood all around the body. So if we do the next poll question, which vessel will supply the heart muscle with blood?
I'll just bring that up now.
Okay, that's great, thank you.
Okay, so that one's launched. That should be on everybody's screens now.
Great. So again, even if you don't know, just have a guess, completely anonymous, and we'll go through the answers afterwards.
I was a lot quicker this time. I think we're like nearly above 300 already, so
Oh wow,
that's really good.
everyone knows.
So, okay, looks like it's kind of stopped around there.
Oh, okay, cool.
5 seconds. Right, I'll end the poll and I'll share results for you to talk through.
Oh, great again. So 75%, yeah, got it right. It is the coronary arteries. So yeah, they need oxygenated blood, these heart muscle cells, in order to function properly. So we'll go through the different coronary arteries now. There we go. So first one we've got is the right coronary artery. And this one branches off from as soon as the aorta comes out of the heart, carrying that oxygenated blood from the left ventricle, and supplies the right-hand side of the heart. Also supplying the sinoatrial node and the AV node as well. So as you know, the electrical impulse starts at the sinoatrial node, travels down through the atria to the atrioventricular node, and then that spreads the impulse then through the bundle of his into his Purkinje system, and then the ventricles contract. And then we've got the left as well, supplying, obviously, as it says, the left-hand side of the heart, coming out from the left side of the aorta, and supplying the left ventricle, left atrium. And the interventricular septum as well, which is the wall that separates the left and right ventricles, just in the middle of the heart there. And you've also got the circumflex artery as well, and that quickly turns around and supplies sort of the back side of the heart, which we call the posterior side of the heart. So there are branches that come off of these, but these are the sort of three main ones that you really need to know for your anatomy, and the three that will become blocked most often. So quick question to test if you've just been listening, and get the next poll question up.
Yeah, answers are flying in again for this one.
Good. I hope so.
I'll give that another kind of 10 seconds or so, just so everyone's got a chance to get the vote in. Right, looks like it's kind of stopped coming in now. So I'll end that poll and share the results for you.
Oh, that's great. 73% view of right coronary artery. That's exactly right. So the sinoatrial node itself is placed in the right atrium. So that sort of helps you remember it, right-hand side, right coronary artery. So good job, guys. So we talked about infarction, meaning that not enough blood's getting to those heart muscle cells, which is causing them to die. So something's happening to that blood for it to become blocked. So this is what happens to the coronary arteries. So we get plaque formation, which happens when, so this inner layer called the endothelium, it gets damaged. And then you get this buildup of like smooth muscle cells, fats, calcium deposits, all building up all this nasty gunk, getting into your arteries. And then this plaque can rupture, break off, which causes platelets, which are the cells that help your blood to clot. They aggregate and cause a massive blood clot in your coronary arteries, which then cause the vessel to become blocked. And then once the vessels themselves are blocked, not enough blood's going to get to the heart muscle, and heart muscle cells can actually die within 15 to 20 minutes. So it's actually quite a quick, effect. It needs fast treatment, and it's something that can cause a lot of damage very quickly. So we're going to talk about risk factors now. Risk factors are something you'll come across a lot. It's something to talk about when we're thinking about who's most likely to get these sort of diseases. So first of all, we've got diabetes. So I've got a quick question for you to check your understanding of diabetes, if you've hopefully done a little bit already. So if you get the next poll question up.
So this is poll number 4. Okay, launching the poll now.
It's great. Perfect. I feel this is quite a difficult one, so just have a guess even if you don't know.
Is this something you'd normally cover at A-level, or is this kind
So
of first year medical school, do you think?
I think it's something that possibly comes up in A-level, especially if you've done human biology, I think. And if not, it's definitely some really important information that you'd want to know for first year, and it comes in handy. So I tend to learn best through answering questions, even if I get it wrong. So yeah, having a go now and seeing what the right answer is, good for learning.
Yeah, definitely. So we'll just give that another kind of couple of seconds. It looks like pretty much everybody's been able to vote now. So we've got a hang of the voting system. So I'll end the poll now and share the results for you.
Perfect. There we go. That's good. So I'm happy with that. Happy with 48%. It is the beta cells which produce insulin. So as you know, type 1 diabetes, which is the genetic form, that means the beta cells aren't producing enough insulin to control blood sugar levels. And type 2 is reduced sensitivity to insulin, which tends to be affected by lifestyle factors. So it tends to be older people, tends to be maybe people with poor diets, people who are obese, things like that. So that's a good job, guys. Previous coronary artery disease. So as I was talking about before, you get the fatty deposits, the plaque. That build-up is going to increase the risk of you eventually having a heart attack. And if you've had it once before, you're more likely to get it again. So there's that one as well. High blood pressure. So as I was talking about before, that damage to that inner layer of the blood vessel, that's more likely to happen with high blood pressure. Blood's pounding against those vessels, and they're going to become damaged, and the plaque's more likely to form. Same with high cholesterol. That plaque is going to build up rapidly, and those fatty deposits, they're going to block off the artery, and if they become ruptured, obviously going to cause a heart attack. Smoking as well. That's one thing you'll learn in medical school. Smoking, if in doubt, put it down as a risk factor. It causes a lot of disease and increases risk of a lot of things. So that also damages the inner layer of that blood vessel. Family history as well. There's a lot of genetic components to a lot of diseases, and this included, even though you might not expect it. As you can see here, people with a family history, say a parent who's had a heart attack, they're much more likely to therefore have a heart attack in the future. So that's something to consider when you're taking a history. Make sure you're asking them about anyone else in the family with heart disease, because that can give you a clue in the right direction. And obesity as well. People who are obese tend to have high blood pressure, high cholesterol. All these factors combined means that you're more likely at risk to form these plaques, and these plaques to rupture. So you've got a patient coming in. This is the first thing that you're always going to do with a patient. You're going to take a history. It's one of the really, really key skills of medical school. And I mean, I still make mistakes. I still miss things. It's a really tough thing to get down. But once you know the right questions to ask, you'll be able to get so much more information. So someone comes in, they said, "Doctor, I've got this chest pain. Which questions do you want to ask next?" So we'll put the next poll question up.
Okay, that should be up on the screen now.
Perfect.
So are these the things that get tested in your OSCEs? Is this the kind of thing that you'd be kind of tested on?
Yeah, so a lot of it's, especially at Manchester, very communications based, and history taking is so important. There's so many things that you can miss. So making it really patient-centered is so important. Getting all the information you can, and it's quite a short time as well. Like you go to GP, you've got 10 minutes. So it's important to ask the right questions. So.
And I just said the word OSCE there. Do you want to just like quickly explain if anybody doesn't know what an OSCE is yet?
Sure. So it's objective structured clinical examination. So you'll basically go in with your stethoscope and your smart stuff, and you'll have, say, 10 stations, 10 minutes each. and you'll go around and the examiner will say, right, this person's come in with say like this chest pain. I want you to take history and come up with a diagnosis. So there'll be an actor there who will have a script that they've learned with special points that you'll have to try and pick up on. And then basically someone's just sat in there and marking you. Examinations can come up as well. They'll ask you to examine their lungs or something like that. So yeah, it's just a variety of things. So it just takes a lot of practice.
It's just like a practical MMI essentially, isn't it? Like a multiple mini interview, but practical.
Yeah, definitely.
So it looks like the results are in for that one. So I'll post the results for you now.
That's great. Oh, that's great, guys. I mean, considering you've not done any history taken so far, it was really good. 63% if you get in. Can you tell me more about the pain? So I'll go through why we wouldn't ask the other one. So is it a stabbing pain? And that's a really, really specific closed question. You're basically putting words into the patient's mouth, which is something you don't want to do. You really want to get the patient's own description of how they're feeling, any ideas of what it could be. They might, they might describe it as crushing pain. If you ask them, is it stabbing pain, they might just be like, oh, yeah, it is. And that might put you in the wrong direction of your diagnoses. So you really want to start off with open questions, make it really patient-centered, rather than sort of asking yes or no questions from the start, because it can put you on the wrong track if, say, the patient has an odd answer to one of your questions. So have you had heart problems before? It's a good question to ask down the line, but close to the start, you really want to get to know what that pain's like, so that you can sort of form the differential diagnoses in your head. So it's great asking it. We start off with presenting a complaint normally, asking them about the pain, and then we go on to sort of past diseases that they've had. But again, it's quite closed. There's a lot of other things that can cause chest pain as well, not just the heart. So you've got the lungs there as well. Might have a blood clot in the lungs. They could have a musculoskeletal injury. They might have pulled something, lifting a heavy box. So sort of thinking straight away it's a heart problem probably isn't their best route to go down straight away. So you wouldn't ask that one. And then this one, can you tell me more about the pain? It's a really nice open question to go on from, makes it really patient-led. I think patients really like it when you let them talk and discuss it, rather than asking them really direct, close questions. So like you could ask, can you describe the pain for me as well? Those would both be really, really good questions to ask. So good job with most of you getting that. So symptoms as well. This really helps you form a differential. You'll get to learn all the different symptoms for all different diseases. It's a lot, but once you know the really defining symptoms of each disease, it really helps you form those differential diagnoses. So people tend to describe it as a crushing central chest pain. Often they'll make sort of hand gestures like that, which really sort of points you in that direction. Sometimes radiates to neck, jaw and shoulders. So this is a really specific trait as well for a heart attack. People often complain, oh my God, my arm's really sore as well. And it's really strange, but often as well, there's been reports saying women often don't present in the same way that men do. So this, even if a woman comes in, doesn't present with this, don't always rule out, oh, it can't be MI, the myocardial infarction, if it's not spreading that way. It's just something to keep an eye out for that may point you in the right direction, but doesn't necessarily mean that it's definitely that. Shortness of breath as well. That's something that's quite common with a lot of things, but putting it all together as one picture could come in handy. So nausea as well. They're in a lot of pain. They're not going to feel great. Dizziness. The heart's not pumping properly. The heart muscle is dying. It's not going to pump as effectively. So that's not going to get to the brain. causing dizziness, which is a really important sign, and sweaty and clammy skin. So when something like a heart attack happens, your fight or flight response is firing. You're not going to feel great. You're going to look pretty bad. People tend to look quite shaken when they come in with a heart attack. So that's quite a telling sign. And there's also one really, really unusual symptom, which I think is really cool. So if we get the next poll question up.
Yeah, sure. It is quite a cool one. So let's see who gets this one.
It's quite tough to come up with the other options for this, trying to throw them off, because it is so unusual. But a lot of patients have come in and said that they've experienced this.
So we're about 250 votes in so far out of 350. So I'll just give it another kind of couple of seconds.
Yeah, great.
Do you think you would have known the answer to this one if you were in kind of year 11, 12, 13? Or is this only something you've
Oh, no, I don't think they've even taught this in first year. It's just sort of something you pick up. I feel like that tends to be the way you learn when you're in medicine. You get thrown so much information, you just pick up the most random stuff, and things like this that are really kind of quite cool or interesting tend to stick with you. So hopefully once you guys see this today, you won't forget it. You'll keep that with you for when you go and study medicine.
Are you ready for the results?
Yeah, go for it.
It's really, really close.
Is it?
Yeah.
Oh, I feel like it may have been swayed with all the COVID-19 stuff that's going on at the moment, because that is, losing sense of smell is a symptom of that. But the right answer is a feeling of impending doom, which is really strange. But yeah, they come in and think, oh, like before the symptoms happen, before the chest pain, like, oh, they can feel like something bad's about to happen. I don't know what causes that, but yeah, it's something I thought was really, really interesting. So hopefully you guys can remember that for the future. So you've taken your history, they've got that typical chest pain, it's spread into their arms, their jaw. What are you going to do now? You're going to investigate. You don't want to just go in straight away from the history thinking, oh, definitely a heart attack, and do all the medication for that, when, oh no, it could be, you know, something else that's life-threatening, and you may miss something really important. So you really want to confirm your diagnosis and make sure you can target your treatment really specifically to when you know you've made the right decision, made the right diagnosis. So there are a few tests that you can do. So first of all, ECG stands for echocardiogram. So that looks at the electrical activity of the heart. So as I said before, you've got the sinoatrial node, the atrioventricular node. The heart runs in its own sort of electrical system. And this can track that. You put these weird pads on your hands and your chest, and you're connected to the leads with this machine, and that has a look at your heart. I won't go through how it works now because it's really, really complicated, and even I struggle to understand it sometimes. But one really, really important sign to know is that you get this really big change here called ST elevation. And you'll get thrown so many of these when you're on your cardiology placements. So that's always going to be a death of the heart muscle, and there's going to be a myocardial infarction there. You're going to do some blood tests as well. Blood tests you'll basically do for every patient, just to get the basics down, know what their health is usually like. And one really important test that we do if someone's coming with chest pain is test their troponin levels. So that rises in response to death of cardiac muscle, which we discussed happens because the heart's not getting the blood supply it needs. So as you can see here, the sort of ratio of troponin rise correlates to the actual size of the heart attack. and you see that huge rise there with that really massive heart attack. So that's a really, really important test. And if that's positive, along with the ECG, you're quite confident that it's going to be a heart attack. And you're also going to have a look at your electrolytes as well. So your sodium ions, your potassium ions. As you remember, I think you cover this in your GCSEs where, or your A level, where you're looking at sort of sodium going into the cell, causing the cell to become positive. I mean, the same sort of things going on in the heart. And if they're not at the right balance, that can cause your heart to beat irregularly. And then that could potentially increase the risk of you having a heart attack. So it's important to check those as well. So could we have the next poll question?
Yep, sure.
Please, thank you.
There we go, it should be up on the screen now.
So yeah, does a raised troponin always mean it's an MI, a myocardial infarction, or heart attack?
It's just gone over 300 votes now, so we should be nearly at the end very, very quickly, actually, at the end of this poll. Okay, cool. Looks like it's slowing down, so I'll share the results with you now.
That's great. So yeah, it doesn't always mean it's an MI, although it's a really, really good marker for it, and it's used all the time. It can rise in response to other things as well, such as kidney disease, infections in the bloodstream can cause it to rise, a blood clot in the lung. So I think the thing is with medicine, all these tests at your disposal. You can't just rely on one. You've got to put the picture together. You've got to reason in order to form your diagnosis. I mean, your history is definitely the most important to that. And then add on your investigations and examinations afterwards, and make sure that you've weighed up, okay, this test's positive. And then they've also said this in the history. Oh, there we go. And then go from there and form your management plan from there. So yeah, use all your different tools because you've got a lot. Let's go to the next one. So management. So you've got different problems that you need to solve with a heart attack. So first of all, they're in pain. It's really, really painful. They've got that crushing chest pain. You're going to need to sort that out first, really. So paracetamol is not going to cut it. So we're going to give them some morphine. It's a really strong painkiller. Does have some side effects which you have to watch out for, but that should hopefully deal with the pain. And you just carry on monitoring them. Ask them, has it helped? Do you need to alter the dose at all? There you go. And then you want to stop it clotting anymore. So you've got all those platelets building up where that plaque's ruptured and that vessel's becoming completely blocked. So you want to stop that carrying on. So you're going to give them aspirin or this drug called clopidogrel. Both of these are going to stop those platelets building up. And it can also be used just in the long term as well to stop it happening again. So they're two really important drugs, and definitely keep an eye on those drugs. You'll see them come up all the time. They might have low oxygen as well, so you want to keep an eye on their oxygen going around their blood. So for that, we'd give them an oxygen mask, and there's loads of different oxygen masks. I don't know them all. Tend to just look at the guidance that they have in the hospital. That's a really important one there. You don't want them having low oxygen because that can cause even further problems. If the brain's not getting enough oxygen, then you're in real trouble there. And then finally, you want to get that blood flowing back to the heart. You want to expand those blood vessels, get them to vasodilate. So we're going to give them some nitrates. That just causes them to relax, sort of open them up. That blockage isn't going to be as significant if the vessel's wider. And you're going to make sure those blood's going to all those branches of those coronary arteries. So the heart's getting enough blood even while this is going on. So I thought I'd show you a quick video of what we call percutaneous coronary intervention. So a heart attack isn't just managed medically. There's also procedures that you can do as well, which the cardiologist can do. And it was quite difficult to sort of explain it, so I thought I'd show you a video. Here we go.
Coronary intervention. An incision is made to isolate the femoral artery. A catheter is inserted into the artery and guided up the aorta to the heart. Live angiography is used to guide the catheter to the obstructed coronary artery. Radiopaque dye is injected into the artery. Imaging determines the location of the stenosis and the diameter of the vessel. Once the vessel is isolated and the obstruction located, a guide wire is threaded through the catheter to the location. The catheter is removed, leaving the guide wire. A balloon catheter is pushed over the guide wire and centered over the blockage. The balloon is inflated to open the narrowed vessel. The balloon is inflated and deflated multiple times to gradually widen the occluded vessel. To ensure that the artery remains unobstructed, a second balloon catheter with a stent is threaded to the location. The balloon is inflated, expanding the stent. For some patients, drug-eluting stents are used to decrease the chances of in-stent stenosis. Drug-eluting stents are coated with a material that will retard new intimal hyperplasia. Blood flow through the coronary artery is restored.
So there's a lot of weird new words there, but in terms of just summarizing that, they just put a wire in through your femoral artery, up through the aorta, and into those coronary arteries, blow up a balloon, and then put these metal plates round to stop, to basically open up the vessels so that the heart's getting enough oxygen. So yeah, that's pretty much everything I wanted to cover today. So you guys have been using the Q&A section, and yeah, any questions that you've got, feel free to use the Facebook as well. I'll be on there for the next hour or so.
Yeah, that was really good. It's so interesting to kind of see the video like that when they do it is essentially surgery, but it's so non-invasive but so effective.
Yeah, and the patient's
isn't it?
fake and everything. It's mad. But yeah, so effective. It's completely life-saving. Yeah.
Yeah, so if you've got any questions, guys, use the Q&A down at the bottom. And if there's a question that's already been asked, then just use the upvote thing as well. And we'll start answering some of those. So we'll do kind of maybe 15, 20 minutes worth of questions. Is that okay with you, Minnie?
Yeah, sure. Okay, so this one's got a lot of upvotes. Which textbooks do you recommend for year 12 to 13's reader they want to learn some anatomy or physiology first year? Okay, I've actually got one here right now. Oh, breaking the camera. So it's this massive one here, Moore's. This is one I use, and it's really good because it gives you a lot of the diseases and information about those as well, and all. It's very sort of clinically orientated and gives you some of the treatments as well, the procedures that they use. I mean, anatomy is a lot and it's very dry, and I mean that took 3 years to cover. So I'd maybe start off with some really good websites as well. There's teachmeanatomy.com. I found that's really useful and really summarizes it quite well. But I mean, it's really difficult to learn anatomy, and I found the lectures are quite overwhelming sometimes. So yeah, it's just a lot of memorizing, and I'd recommend also making flashcards as well. I found flashcards is a really good way to learn anatomy. If you find a good set of those, I think you can buy some on Amazon as well, or you can make your own. That was a really good way to maybe get ahead. See what else we've got.
Cool. The next question on there is, are we going to get proof of us attending this meeting? We haven't made any certificates. I didn't realize everybody wanted certificates, but maybe in the future, for like future webinars, we'll kind of do some kind of digital certificates or something if people want those. Didn't realise you wanted them, but yeah, we can do it for future ones.
Yeah, I think for interviews and stuff and your personal statement, they don't tend to ask for proof. It's only really when you've gotten into medical school and you're going on to sort of finding jobs, then they'll ask you. So yeah, don't be too worried about stuff like that. Okay, has corona impacted on number of heart attacks? I wouldn't know for definite. I have heard about a few cases though of it causing heart attacks and those blood clots in the lung. I think it's known to increase clotting in the blood. So I'd say possibly. I'm not sure about the numbers themselves, but it definitely does cause increased clotting. How does diabetes increase likelihood of heart attack? So diabetes, a lot of problems are associated with diabetes, and one of those is vascular damage, so damage to those blood vessels. So just one of those problems would be sort of in those coronary arteries, causing that damage, causing that plaque to form. But you can also get problems, say, in the vessels in your eyes as well. In your feet and your toes, you can lose sensation there because of loss of blood flow. So diabetes does cause a lot of problems that you wouldn't necessarily think about. It's not just sort of controlling that blood sugar and having high blood sugar. It's there's a lot of complications there. So I hope that's explained that. What are the side effects of morphine? So morphine, it can decrease your respiratory rate. So a lot of patients that are on it are quite zonked. So you have to be really careful that they're getting enough oxygen in. So it's just keeping track of their oxygen saturations. And it also can make you feel quite sick as well and nauseous. So we give them what we call an antiemetic, so it basically stops them throwing up. So they're the two main ones to worry about with morphine. Why does a pain radiate in this way? I don't think anyone really knows. There's quite a lot of speculation about how it works with sort of the way the nerves are organised, about them crossing over sort of when they enter the spinal cord. So there's no certain answer really, but it's just one of those things you sort of just learn right off by heart. So there's like, if you've got pain in your gallbladder, that tends to spread to your shoulder tip. It's just with the way the nerve supply works, but yeah, there's no consensus about, you know, how it officially works. Do you have any recommendations for wider reading? It's really hard at this stage because there's quite a lot of sort of basics you need to get down for the sort of big, you know, textbooks to make sense. But there's a textbook called Kumar and Clark, Kumar, and then Clark, Clarke, and that's really good for basic physiology, things like that. If you want to get ahead, that might be a good one to start with. Why did you pick medicine? Well, my mum's a nurse, so that sort of healthcare chat has always been in the family. I've always found it really interesting, all the weird stories that she come back with. And I just like how people orientated it is. I love chatting to people. I found that side of it much more fulfilling than maybe the real sciencey side, which sometimes you get a bit sort of just drowned in. So yeah, I think it's a really, really nice career to be in, and it's so nice to sit and chat with patients all the time. A lot of time we spend on the wards now, we just go and sit with the patient for an hour and, you know, you take the history, but you can have a quick chat with them about family. It's really, really nice. And I've absolutely loved it as well. So wouldn't pick anything else. So I hope you guys, you know, when you get in, you enjoy it. Make the most of it. It's busy, really busy. But yeah, it's great fun. What are the alpha and gamma cells used for? This is a tough one. I've not done this in a while. If I remember, yeah, gosh. So if I remember, the alpha cells, they secrete glucagon, which is another hormone that controls blood sugar levels. And gamma cells, I would have to look that up. So I'll leave that for you guys as wider reading.
That's a good
I
way
don't want to
to
give you the wrong answer. What was it like to study at St Andrews? Oh, I absolutely loved it. Absolutely, I couldn't imagine being anywhere else. Like, amazing university. If you like it being quite small, I think it's really nice. There was only about 150 in the year, so you pretty much know everyone. Balls all the time. If you love dressing up in your heels and getting your tuxedos on, it's a place to be, really. Lots of beaches. Yeah, loved it. Someone's asked about the pros and cons there. I'd say pros is you get really good anatomy teaching, like really good. So full body dissection, lectures are great, very sciencey. So if you really like the basic science of medicine, it's a really good place to be. Cons, I think just how small it is. It's quite tight-knit community. So I think it's just, well, I don't know how to describe it. Like, if you've got a broad range of interests, sometimes that's not met there. Like, there's very limited sort of society sort of and clubs. But I think it's definitely worth applying. I've loved it there. So yeah, would recommend. And then someone's asked about Manchester as well. I've really enjoyed Manchester as well. Very different to the St Andrews style of teaching. It's much more communications based, and you sort of format your own learning. So I think if you want to be more independent and get really good at the patient side of things, Manchester's a good place to go. And then St Andrews, if you really want that knowledge base, that's good. My uncle's in his 20s, had a heart attack, and wasn't a smoker, obese, active and healthy. What might cause this? I wouldn't be able to say. I mean, the risk factors I listed there are, as I said, just risks. They're not necessarily the causal factor. So it perhaps could be maybe a genetic thing, maybe if it's something that runs in the family. Yeah, epilepsy might have been a factor. I don't know. Epilepsy, I think that as well is something they're not sure completely how it works. So the sodium ions in the brain. So I mean, it makes a dissertation idea for when you're in your third year of medicine. You can see if there is a link. Might be something to read up on. Tips on personal statement. I'd say that don't get bogged down with reading books and things like that. I think they really want to see that you've committed to medicine as a career and are getting hands-on and involved in, let's say, a hospital or a care home, a hospice. I think that's what really sold it for me, is like when I did a year in a hospice, and I think that really showed like sort of caring side. A lot of people get really good grades, things like that, but showing that you're really committed and actually want to, you know, work, and that would be my tip. Would just be, yeah, get involved practically as much as you can, do some volunteering. I've heard of something that is called broken heart syndrome. That is, I think that's Kawasaki disease. No, it's not. But there are a lot of heart problems that can get mistaken. As you can tell, there's a lot of stuff to learn, so I don't actually remember the physiology for this, but stress cardiomyopathy. So this is something that's really odd because it literally is broken heart syndrome. So if something really stressful happens in someone's life, say a death of a family member, then they actually can present with really bad chest pain. But I'm not actually completely sure behind the physiology of that. So it's worth looking up. God, I need some water. You bear with me 1 second.
I'm sure she'll be back in a minute. Just to let you know, we will kind of send out the recording of this probably within the next 2 days. So just check your emails for that. And yeah, we'll probably send out the slides as well. So if you want a copy of these slides, then we'll send that out with the recording in the next kind of 2 days or so. We've still got like 200 questions. So what we'll do, I think, we'll probably take maybe like one more question on here. And then what I'll do, if Minnie still wants to, then what we'll do is we'll post a link to our Facebook page. And if you want to ask any more questions, I'll put a post on there. And if you put your questions in there, then we can carry on answering questions over there. So it's not kind of making this webinar on for like 2 hours. So yeah, if we find one more question, and then we'll jump on to we'll end the webinar, and then we'll jump onto the Facebook page.
Yeah, that sounds good. Can a blood test be done fast enough to get results back in time? So as I said, like the troponin, that can be done pretty quickly to confirm it, but a lot of it is really based on what the cardiologist thinks. A lot of the time they'll do the ECG, they'll see that ST elevation there, and then combined with the symptoms that they've got, they'll probably just send them in for that procedure, the percutaneous coronary intervention. But if it's not too severe, if they've got other diagnoses that they're thinking of, they won't necessarily, they might wait for the blood test results. They'll probably give them aspirin anyway, and then possibly some nitrates, just because nitrates will actually tell you quite a lot of the time whether the pain is coming from the heart. So if that eases the pain, then it is quite a telling sign that, oh yeah, it is a heart attack, and then something needs to be done about that. So yeah, they'll try and do the blood test, but if they're pretty sure, then a lot of the time they will just go for PCI.
Okay. Yeah, should we leave it there kind of on the live webinar, because that's like just about an hour. What I'll do, I'll post the Facebook page link in the actual chat so people can find the Facebook page. And then if you're around for the next kind of hour or so, if anyone's got any more questions, they might just kind of ask them on there so you can reply to a few more people. When we end the webinar as well, I think it takes you to a survey page. We're trying to get feedback on all these different types of webinars, so it takes literally like a minute if you want to just let us know if you enjoyed it, and then we can at least rate how we're doing, and we can keep doing more of the webinars that people want to see. But yeah, we'll wrap it up there. Thank you very much everybody for joining us, and we'll see you on the Facebook page if you want some more, and then we'll post up some more webinars in the next kind of few days, so just check back on the website, and hopefully we'll see you again soon. All right,
thanks for joining.
Thank you very much everybody
for your applications. Nice to see you.
Thanks Minnie, thanks for your time as well, we really appreciate it.
Cheers, it's having me.